I am Agustin Ibañez. I am the director of the Latin American Brain Health Institute. I am also Senior Atlantic Fellow of the Global Brain Health Institute and Associate Researcher of the Trinity College Dublin. Biomarkers are critical for the development of dementia, and in particular for frontotemporal dementia. But the most standard or mainstream biomarkers, like those provided by the ATM framework, present several challenges for global assessment. In particular, PET studies are extremely expensive for the developmental world. Less than 1% of the patient can have access to this technology across Latin America, and this is not a cost-effective technology. So we need to develop biomarkers more scalable, less expensive, and by another hand, in the BBFTD, we don't have developed yet such robust PET biomarkers as in the case of AD. I think that plasma biomarkers will represent a strong progress in the future, but this is another discussion. So neuroimaging methodologies, including magnetic resonance imaging that provides the structural view of the brain, diffusion tensor imaging and resting state fMRI that provides connectivity, structural connectivity and functional connectivity of the brain respectively, and other methods or modalities like the FLAIR that provide, cardiovascular or vascular impact assessing white matter hyperdensities in the brain are very powerful sources to characterize disease subtypes, disease progression, and early markers of dementia. Still, they have many challenges. So regarding atrophy, there is a huge variability. You can have patients with a large atrophy without having dementia, and quite the opposite, patients with dementia that doesn't have a strong atrophy. This is one problem. The other problem is atrophy localization. In general, in frontotemporal dementia, you will have atrophy of frontotemporal and insular region. You usually find early atrophy of the orbitofrontal cortex and amygdala, but this is not always the case. And there is a huge variability in the atrophy. When you look at functional connectivity and DTI to the networking of the brain, as the brain is a complex organ that continuously interacts and self-organizes in response to environmental demands, studying the connectivity between brain regions is a huge, very promising approach. In that regards, the problem is again variability. Usually the typical result is the salience network, that is a network that involves specific brain of specific brain areas like the anterior cingulate cortex and the insula, is a network indexing, the salience of environmental signals associated with social cognition and counter activated regarding the default mode network is another network that we will talk about. But this salience network is typically affected in BBFTD. And AD, for instance, the default mode network is typically activated. This default mode network is the network that is active when you are not doing nothing. So when you are having mind wandering, for instance, you tend to have this default mode network activation that is more sensitive in AD. That sounds like good news, right? So you can have specific markers for salience network for FTD and specific markers for AD using the default mode network. But this, again, is not always the case. There are cases of early frontotemporal dementia or genetic presentation of frontotemporal dementia that doesn't have a clear impairment in the salience networks. Then you have patients with dementia that have impairment in the salience network. You also have patients with frontotemporal dementia that have different levels of the default mode network. And the same with the cardiovascular aspect. We tend to think about neurodegenerative conditions as completely different regarding vascular dementia. But this is not true, or this is not true, especially in the global south, where you have a huge impact of cardiovascular disease. And vascular components can have a strong impact in neurodegeneration, particularly in AD, but in FTD, we still need to learn in that. So a very important challenge in the biomarkers approach of neuroimaging is combining all these modalities. So we have a kind of naive illusion to identify a single biomarker with a single condition. This has been the hope for all the beta amyloid research in Alzheimer's disease. But dementia, not only Alzheimer, but all dementia, in particular frontotemporal dementia, are extremely complex and heterogeneous conditions at different levels, at proteinopathies, at brain level, and metabolic level, at cognitive level. So we need to develop more combined set of biomarkers. In that regard, multimodal neuroimaging, the combination using, for instance, artificial intelligence, when you use machine learning to identify different features from atrophy, from structural connectivity, from functional connectivity, for white matter hyperintensities, and you can combine these different features to predict, the classification of one disease as AD versus FTD, for instance, or as a more progressive or less progressive condition, is a very powerful approach. We need to develop for that larger samples because, in machine learning happens something that is sometimes different than in parametric models. You can have huge classification power in small samples because, your technique is so powerful, so overfitting happens. Overfitting means that the computer can understand the structure in your own data at different levels and can make a perfect classification. But then when you want to extrapolate the result to other samples, it doesn't work. So for that, you need a lot of data to have ways to avoid overfitting and to make out-of-sample validation of your machine learning process. So I think that a very important step is creating large databases and being able to implement machine learning really efficiently and being able to identify different combinations of different neuroimaging modalities for to characterize the disease. In the same line, trying to identify more affordable, scalable, and massive biomarkers, especially for the developmental work. That is the area of the world that will have the largest numbers of dementia patients in the future. We need to focus in scalable and portable markers. In that regard, EEG or electroencephalography is a technique that measures the brain electrical activity, has been mostly neglected in the mainstream research of dementia. But in the last 10, 20 years, there have been a huge progress in the improving the signal-to-noise ratio, improving the methods to infer the different sources of brain activity, and also improving the technologies to making the EEG more portable, using dry electrodes, giving the amplifier to the people so the people can go home and having recordings during the day, during the night, doing different activities. So in the near future, EEG can be a powerful complement to other plasma, PET, or neuroimaging modalities. And I think that many research groups have started to think about in a more complex view of dementia, trying to assess different levels. And I think that EEG can add a plus for this approach.